Vidya. I feel very happy and proud to introduce our judges for today's topic. Dr. R. Padmapriya ma'am, she is my very own assistant professor when I did my postgraduate at Salem Medical College. She graduated her MBBS from Chengalpet Medical College, DGO from IOG MMC, and MDOG from Government Keelpark Medical College. She has 26 years of service experience and currently working as professor in Department of OG, Dharmaburi Medical College. Her field of interest is in high-risk obstetrics. I welcome you, ma'am. Thank you, ma'am. Dr.
Thank you
Ishan.
for your introduction.
Thank you, ma'am. Next judge is our Dr. E. Shanti, ma'am. She's Professor Department of OB-GYN at Savita Medical College and Hospital, Chennai. She did her MBBS from MMC and MDOG from IOG MMC. She has been trained in USG and Advanced Infertility Laparoscopy and also a provider and instructor course. She has various publications and her field of interest is on endoscopy, high-risk pregnancies and adolescent gynecology. We welcome you, ma'am.
Thank you.
Thank you, ma'am. We have two postgraduates who are going to present the case today on fibroid uterus. Both are doing second year PG at Karpagavinayaka Institute of Medical College, Madrandagam. Dr. R. Hemavati and Dr. Kanagasudha. Over to the case presentation, ma'am. The judges can take over. Thank you, ma'am. PGs, you can continue with your case presentation.
Good evening, ma'am.
Good evening. Good afternoon. Welcome both of you. It's really nice to see young minds here sitting, very anxious to attend this session. So I wish you all the best to go ahead for the presentation.
Sharing the screen.
Yeah, sure.
Good afternoon, ma'am. Case presentation is on the presenters are Dr. Hemavati and Dr. Kanagasudha, second year postgraduates from Karpagavinayaka Medical College. Chief complaints, Mrs. X, 40 years, coming from Padalam, a para 2 life 2, previous 2 normal vaginal deliveries, sterilized, homemaker by occupation, belonging to socioeconomic class 3, presented to OPD with complaints of heavy menstrual bleeding since 1 year, easy fatigability and dizziness for the 2 months, and associated with complaints of abdominal distension for 6 months, and now was admitted for further management. History of presenting illness. Patient was apparently asymptomatic 1 year ago when she started to experience symptoms of heavy menstrual bleeding lasting to 7 to 10 days per cycle and changing 4 to 5 fully soaked pads per day, associated also with passage of clots, and history of pain during menstruation, and history of abdominal distension for 6 months, and history of easy fatigability and dizziness on and off for 2 months. And no history of intermenstrual or postcoital bleeding, no history of frequency, urgency of micturition, and no history of any urinary retention, and no history of constipation, no history of any mass descending per vaginum, no history of white discharge per vaginum, fever or abdominal pain, no history of loss of appetite, no history of loss of weight, no history of cold intolerance, no history of secretions from breast. Sorry. No history of swelling of leg or breathlessness or palpitations. No history of intake of any anticoagulant, antiplatelets or bleeding tendencies. No history of intake of any hormonal pills. Menstrual history. A patient attained menarche at 13 years of age. Past menstrual cycles, regular, 4 by 30 days cycle, changes 3 pads per day, and was not associated with passage of clots and pain. Now present, for the present 1 year, the cycles are regular, but side length has increased to 7 to 10 days and changed 4 to 5 pads and associated with passage of clots and also complaints of dysmenorrhea. And her last menstrual period is 12/7/2026. Marital history, married for 18 years and non-consanguineous marriage. Past history, not a known case of diabetes, hypertension, coronary artery disease, epilepsy, TB, asthma or thyroid disorders. No history of any transfusion or iron sucrose injections in the past. Pubertal sterilization was done 14 years ago. Other than that, no history of any surgeries. No known drug allergies. Past obstetric history, para 2 life 2, First was a male, 18 years old, full-term normal vaginal delivery, delivered at Chengalpattu GH, alive and healthy. Breastfeeding was done for 1 year. Postpartum period was uneventful, and postpartum IUCD was inserted, which was removed after 3 years. And second pregnancy was a boy baby, 14 years old, alive and healthy, full-term normal vaginal delivery, also delivered at Chengalpattu Medical College, Chengalpattu Government Hospital, and breastfeeding was done for 10 months. Puerperal sterilization was done. Postpartum period was uneventful. Personal history, mixed diet, normal appetite and sleep, normal bowel and bladder habits, no history of any substance abuse. Family history, no history of any breast, GI or gynecological cancers in the family. No history of any bleeding diastasis or genetic disorders. Summary, Mrs. X, 40 years old, a female, para to life to with previous two normal vaginal deliveries, LCB of 14 years, sterilized, presented with heavy menstrual bleeding for 1 year, abdominal distension for 6 months, associated with dizziness and easy fatigability, abnormal uterine bleeding for evaluation, associated with anemia.
Hemavati, shall I
second.
ask?
Yeah, that's what. From the first,
Yeah.
can we go to the first slide, Dr. Padma?
First, yeah.
Yes, ma'am.
So you're saying heavy menstrual bleeding. Can you tell me, describe what do you mean by heavy menstrual bleeding?
Excessive uterine bleeding
Affecting
the physical, emotional, and social and quality of the life, mom, irrespective of the
Yeah.
regularity, cyclicity, and frequency, mom.
So the quality of life is interrupted. Okay.
Yes, mom.
Okay, what is the positive findings? You have told so many negative points, no? Oh, why do you want to know about the negative points? You have told about
About other etiologies, mom.
yeah.
other etiologies and other any pressure symptoms are present to rule out those we are asking for the other
So
negatives.
you are asking for for each you have to explain. For what you
Yeah.
are asking for, no history of intermenstrual or postcoital bleeding.
Yes, ma'am.
Okay, yeah.
So here it is history of pain during menstruation. Is it sufficient?
Hmm.
You should describe what is this pain during of menstruation. You can just say dysmenorrhea, right?
Yes, ma'am.
Yeah. What do you expect? Is it not necessary to explain that?
Yes, ma'am. It should be explained whether it is a
Type of pain.
Yeah.
What
Type-
type of
What is the type
dysmenorrhea?
of dysmenorrhea? Why is it important?
Spasmodic or congestive
Congestive
means pathology is there means it is a congestive, mom. Primary, there is no etiology will be there, mom. Primary and secondary,
Yeah.
primary dysmenorrhea, there will be no underlying pathological condition, mom. Secondary will be having some etiology.
So here it is secondary. You're right.
secondary
Right?
dysmenorrhea.
Okay. So further you classify it as spasmodic or congestive.
Spasmodic
right?
and congestive.
Or any other
Oh, what?
dysmenorrhea?
Membranous dysmenorrhea, mom.
Okay. Anything else?
Membranous, mom, third type.
Okay. Anything else?
Anything else pertaining to your case?
Oh, our case.
Our case is both spasmodic and congestive, mom.
What is the other one? Triple dysmenorrhea?
Mom, that
That
is
is
in
mainly
adenomyosis or
Yeah.
endometriosis will be having triple dysmenorrhea, mom.
So can this case be a part of adenomyosis? We haven't examined yet, right?
We haven't examined it, ma'am.
So
At this
you
point,
should know, you should describe everything. What is the type of, okay.
Dysmenorrhea.
okay.
Okay, heavy menstrual bleeding, you have lot of differential diagnosis. Keeping in mind, you have to rule out everything in the history itself because history
Okay.
itself will give you almost 80% of your diagnosis, more than that. So just to support your history diagnosis, you're going to do, next will be your examination. Around 90% you can do. And only 10% will be your investigation, which will add on to that information. Okay. So
Okay.
history-wise, you should definitely describe this manner. Okay.
Okay.
So why is it like urinary retention? Why do you ask it?
Ma'am, in case of large fibroids, due to the pressure symptom, there could be a. In
Which
case of a
type
large
of
mark,
fibroid will cause urinary retention?
cervical fibroids, ma'am. Large cervical fibroid.
Broad ligament fibroid.
Broad ligament.
Broad ligament, right?
Cervical fibroids can cause urinary retention. And very large fibroids can also.
Broad
Very
ligament.
large. It is mainly the posterior wall fibroid and probably the cervical fibroid. So especially when do you get this urinary retention? At which point of time? Anything related to menstrual cycle?
Premenstrual phase of the menstrual cycle.
Yeah, whenever the
Yeah,
congested, no?
in
So
the-
you expect this urinary retention, especially with the history itself, we can say that it could be a posterior wall fibroid. If you just go and observe clinically, also we can make out because of the cervix is pushed anteriorly, so it goes and blocks the urethra. Okay, that urethral bladder urethral angle.
Bladder.
Okay, so that is the
So
reason
you've
they
asked
have
for
urinary retention.
intermenstrual or postcoital bleeding. What
Yeah.
could cause in your case? What do you
Submucosal
expect?
Submucous fibroid is more
So any
common.
polypoid projection.
Anything. It can be endometrial also, right?
Yes,
Endometrial.
ma'am.
Mm.
Because
Endometrial
both
colon.
endometrial pathology, that is hyperplasia, as well as the fibroid share a common etiology. What is it?
Etiology.
Uh,
What is the etiology?
it is due to
May not be
Madam
etiology, associated factor.
Yeah.
Yeah. Why should there be endometrial hyperplasia or polyp?
Because of the chronic estrogen and ovulation, there will be endometrial hyperplasia, ma'am.
Okay. Okay. What about fibroid?
Fine. Both estrogen and progesterone, ma'am, there will be cellular fluctuation will be there.
So basically, both are associated with hyperestrogenic conditions.
Yes.
Okay. So that is why you always rule out and try to rule out endometrial pathology also. Okay.
Okay.
Yeah. So here, history wise, you should have everything in your mind. Okay. Because many things can coincide.
Oh.
Okay. So it can be mostly if you see fibroid and adenomyosis will be together. Right?
Yes.
It's not like isolated condition. Many of the times, if you send the specimen for histopathology, you would have observed it. No, if you would have thought it was only fibroid, but then adenomyosis also would be there, right?
Yes.
So
Yeah.
triple dysmenorrhea doesn't mean that in fibroid you may not get it. Yeah, associated adenomyosis can cause triple dysmenorrhea. Okay. So don't get biased with the complaints. Okay, that even if the history shows or if he says like abdominal distension, associated conditions that can be associated endometriosis as well, right? So all this fibroid, adenomyosis, endometriosis, all this can coexist together. Okay, you can just concentrate on one particular diagnosis. Okay, yeah.
Yes.
Next
Okay.
page, please. What is that? No history of mass descending for vagina?
Any fibroid or polyp.
Any fibroidal polyp and total prolapse.
Yeah.
Prolapse. So which fibroid can lead on to some uterine descent or something, a different kind of uterine descent?
Chronic inversion of the
Fundal
Yeah.
fibroid with chronic inversion.
Submucosal fiber.
It is a mass.
Yeah. Okay. Pedunculated, a bit large. It may not be small. It's a large submucous fiber that gets dragging. Okay. And this white discharge.
submucosal fibroid going for ulceration, they cause abnormal vaginal discharge.
Can it be foul smelling?
Infection, associated infection can cause.
Yeah, necrosis, that pedunculated fibroid undergoing necrosis.
Necrosis.
Yeah, and in secondary infection can cause this. Okay. Why is this loss of appetite, loss of weight?
To rule out any history of
malignancies, tuberculosis, diabetes.
Abdominal distension could be also symptom of malignancy also. So to rule out, we are asking.
So no history of intake of anticoagulant, antiplatelets, or bleeding tendencies. Why did you combine this bleeding tendencies here? Is it fitting into that?
Yes, no passes.
Because you don't want to put so many no's, is it? You can't fit that in. Okay. 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 Okay, next slide. So why is this menarche, age of menarche important?
Early menarche is again a risk factor for fibroids adenomasis.
Yeah, that's good. So I think like you have written both past and present here. Present complaints you have already told, right?
Yes, ma'am.
So that was her presenting complaint. So I don't
Yes,
think you need to explain this again because it will be a waste of time as well.
okay.
Okay. So you don't have to mention it here. Huh?
Okay.
So next marital history. Okay, next page. Okay, why did you go directly to past history? What should have come after menstrual history? Marital history. What will happen in a sequence once she has attained menarche, get married, then what will be that?
Obstetrics.
Then
Obstetric.
why did you, as a PG, you can't make this blunder, right?
My realized it only after starting the sharing the
No,
screen.
no, you should make, see, you can't be so careless, right?
Sorry.
Both have sat together and prepared this PPT. Okay, so many are watching, right?
Okay.
It's not about like making mistakes, but be very
Yeah, sorry.
responsible. Okay.
Yeah.
So what past history you want to get?
Any
Mom, thyroid is no history of hypothyroid or hyperthyroid, mom.
So you have definitely got a mass and thing, alla.
Yes,
Mom.
ma'am.
So you arrived at the diagnosis.
Yes.
Your parent sterilization, why? See, why everything is put together here?
Past
Past,
history
you
usually
have
they
to
don't
divide
write.
it into medical and surgical,
Surgical.
right? And
Okay.
no dermatologist. See, you can't put everything together under one history. Okay.
Okay.
So always
Past history only that metabolic conditions, diabetic, hypertension, like that. Past
Okay.
surgical history, maybe you can say.
Okay.
you
Your parent
put it
sterilization.
separately.
Mm.
Okay.
Okay.
That and allergies also it should be like a separate
Separate.
topic like medical allergy. Allergies,
Okay.
it can be to allergies to food, allergy to medicines, or allergy to latex as well.
Okay.
Right, glove allergy. That for then you need to take a lot of precautions when you put catheter or glove. So you have to be very cautious about it. Okay.
Okay.
Okay. Why is it important for your? Why do you want to note all these medical conditions?
Any comorbidities like thyroid could also be again a cause of heavy menstrual bleeding, thyroid disorders, and all the other conditions too. In case of any surgical management required
Starting
to
medical
for the
treatment also we
preoperative
need.
Okay.
preoperative counseling and
Okay. She may not be fit for the surgery.
fit for the
but she
surgery.
will. Okay. So here actually you should talk about the bleeding diathesis or bleeding disorders, right?
Yeah.
But do you think that that history is related to this?
It was common in adolescent age,
It is
mom.
not in
From
the
when? Yeah. From the date start of the menarche. The
menarche.
complaint will be from the menarche. Okay.
Menarche.
So if at all you want to put it, you can put it here. Even if you don't talk about it, that's fine. But that what you mentioned was like blood thinners or whatever it is, that should be there.
Okay.
Yes, ma'am.
Okay. So in past treatment history, you should ask whether she has had any treatment before. Have you
Okay.
mentioned about it? Did you tell?
We have
Did you
only
ask about that? See, that's
yes, ma'am.
very
We
important.
asked.
Unless you ask
Yeah,
the
she's
patient will
having
not.
We have asked, ma'am,
she's having heavy menstrual bleeding for past 1 year. La.
1 year. Yes,
So you
ma'am.
should have
What treatment
any
did she
treatment.
take? Yeah. Did she take any treatment?
Has taken the nearby clinic some drugs she has
Drugs
taken.
she has
Mom, but
You
taken
should
for
not
definitely
You
you
mentioned.
should tell about that.
should definitely talk about it. If you don't have the records, that is a different issue. But then we should know that you have asked for it.
okay.
Yes, ma'am.
Okay,
Yes.
that is a very important history. You should bring it out. And nowadays, before coming to us, the patient directly goes to an ultrasound, okay, center, and they get the scan done and then come with the report.
Yes.
Right? So all these things you have to bring because if she has had some medical management already, and it would be now like it is unresponsive to medical management or she is not happy with the medical management, so you have to go ahead with some other next step of treatment.
Okay.
So to decide upon the treatment also, you need to have that treatment details, okay, and should make sure that whether she may have several prescriptions, but she wouldn't have followed that instruction also. We
Yes.
have come across, right? She will
Yes,
just
ma'am.
have that, they will never
Mm.
take it. So all these things are important regarding the past treatment.
Okay.
Okay, so
Yes,
that you have to. Okay, so make sure that you're bringing out this past history after the obstetric history.
Yes.
Okay, and that too separately: medical, past surgical, and allergies, and then family history, and then at the last will be the personal history, whatever you want. So this is how it could be. Okay. Okay.
Yes, ma'am.
Next. So is it anything contributory? Again, you have written puerperal sterilization done. You understand? So
Yes.
there and again here. Okay, that is actually not a one. Somewhere you should mention it. Okay. Okay. Anything contributory?
No, ma'am.
So generally we expect nulliparity, but that doesn't mean that parity is a protective factor.
Yes.
Okay, fine. Okay, next. So please bring the family history earlier. Personal
Yes.
history will be the last.
Okay.
Okay. So
Yes, ma'am.
personal history, it's a diet, appetite, and sleep. Bowel. Okay. Okay, next. So history of breast, GI, and gynecological cancers in the family. Anything else you want to know?
Fibroidous genetic predisposition is there, ma'am.
Even fibroid you could have asked.
Yeah, fibroid, that's very important. Okay, see, nowadays, like endometriosis, fibroid, preeclampsia, lot of things that run in families. Okay, so fibroid, definitely you should have asked, because we have seen, no, the sisters all coming together
Yes, ma'am.
with the same complaint to the clinic, right? So don't forget about it.
Yes.
Okay. Okay, next.
Next.
Yeah.
We go for the examination.
Yeah.
General examination. Patient is moderately built, moderately nourished. Height 154 centimeters, weight 58 kg, BMI of 26.1. Pallor present, no icterus, no clubbing cyanosis, pedial edema, and no lymphadenopathies. Vitals, BP 110 by 60 millimeters of mercury in right upper arm in sitting position. Pulse rate 101 per minute. Regular rhythm, normal volume and character. Respiratory rate 18 per minute. SpO2 99% in room air. Temperature 98.2 degree Fahrenheit. Local examination. Both breasts, no lumps felt, no discharge from nipples. Skin over the breast appears normal. Thyroid appears grossly normal. No swelling seen in spine and appears clinically normal. Systemic examination. Cardiovascular system. S1, S2 heard. No murmurs or added sounds. Respiratory system. Normal vesicular breath sounds. Bilateral added present. No added sounds. So, CNS. No focal neurological deficits. Abdomen examination.
So
Inspection.
one second. Can I stop here? So based on the history, can you please summarize, provide with the differential diagnosis?
Based on the
She's a
history.
40-year-old Paris lady with heavy menstrual bleeding for the past 1 year, right? So
Yes,
with
ma'am.
that history, so what is your differential diagnosis?
It could be fibroids, it could be adenomyosis, it could be also endometrial.
Any ovarian mass also, ma'am.
Could be
Any ovarian mass or something specific?
Yes, ma'am. Granulosa tumors or estrogen secreting tumors, ma'am. Granulosa cell and thecomas.
Okay.
and
See, just be open. So based on the history, you can give a lot of differential diagnosis, right? So it can be thyroid disorders also associated with how many times we have seen coincidental conditions, right?
Yes,
Yeah, it can be thyroid disorders also. Then why not endometrial pathology? Why did you leave that?
Endometrial carcinoma.
Not why carcinoma. Can be endometrial polyp, endometrial
polyps.
hyperplasia, anything. So polyp maybe additionally you'll have some intermenstrual bleeding, but still you should have that in mind. Okay, start from the endometrial pathology. Okay, endometrial hyperplasia or endometrial polyp, and then fibroid, adenomyosis. Okay, but endometriosis may be quite rare. Not very common as a first presenting complaint at the age of 40. Right?
Yes, ma'am.
Yeah. So these are the various differential diagnosis. Okay.
Okay.
Okay. So keeping in mind, then you narrow down the your examination will support. You have to rule out all these things. Okay. Yeah. Yeah. Go ahead with the.
Per abdomen examination, inspection. Skin over the abdomen appears normal. Abdomen obese. Umbilical is central and inverted. All quadrants moving equally with respiration. 2 centimeters subumbilical transverse scar present. No visible sinuses, dilated veins, or pulsations. All hernial orifices appears free. Palpation. Inspection findings were confirmed. Abdomen is soft. Midline mass corresponding to 16-week size. Firm, non-tender. Well-defined margins. Smooth surface occupying the hypogastric region. Side-to-side mobility present. Lower border not palpable. No other organomegaly. No guarding or rigidity. Hernial orifices were free. Auscultation. Bowel sounds were heard. Percussion. Tympanic note heard over the all quadrants. Local examination, external genitalia appears normal. Perspiculum examination, cervix appears grossly normal. No evidence of polyp erosion or growth seen over the cervix. Vagina appears normal. Bimanual examination, cervix pointing downwards. Uterus is anteverted, corresponding to 16-week size. Fornixes are free, no fornical tenderness. Transmitted mobility from the mass to the cervix is present, and no cervical motion tenderness. Provisional diagnosis, Mrs. X, 40 years old.
Shall I interrupt?
Yes,
Cervix appears grossly normal. What is that grossly normal? You can say a cervix appears normal.
Oh, yes, ma'am.
See, everything like whatever is macroscopically normal, you can say just normal, right?
Yes,
Yes.
I don't think you need to mention all these polyp erosions. If you say normal, then normal, that's it. Okay.
okay.
And go back to the abdominal examination.
Yes.
Okay. Yeah, this is okay. Next. Midline mass corresponding. So you need to write whether it is uniformly enlarged because it's 16 weeks, right?
Yes.
Is it uniformly enlarged or irregularly enlarged?
It is not uniformly enlarged, mom. It was.
Have you mentioned it? Why is it important to write whether it is uniformly enlarged or irregularly
It
enlarged?
was enlarged. It was more pointing towards adenomyosis than fibroid.
You have mentioned it as well-defined margins.
Margins will be well defined, irregular, well defined, okay. But then, see if it is full uniformly enlarged, is
Smooth
different.
surface.
From
Yeah. Okay. So, what are the causes of midline uniformly enlarged uterus?
midline uniformly enlarged mass could be a fibroid, mom.
What fibroid?
Intramural.
Intramural. Intramural.
What
Intramural.
intramural?
If it is single fibroid, it should be midline.
Midline.
Yeah, mostly it will be a fundal fibroid.
Fundal fibroid.
It's a fundal fibroid. Okay. Otherwise, adenomyosis.
Adenomyosis.
Okay. Okay then. Okay, next we can move to the next slide.
Yes.
Okay. So again, your uterus, you could describe it better, right?
Yes, ma'am.
Whether it is what you have done, multiverted and corresponding to 16-week size. Is that sufficient? What information does it give? Lot of things by examining the position. So it is okay. Uterus is 16 weeks irregularly enlarged. Okay, that also you should mention whether it is uniformly enlarged or irregularly enlarged uterus. That is very important. Okay, uniformly enlarged, irregularly enlarged uterus, about 16 weeks size. Usually, you cannot say after once it is 16 weeks, you cannot say whether it is anteverted or retroverted. So use generally. Okay.
Okay.
And whether it is mobile or not, transmitted mobility is different.
Yes.
Okay, it's transmitted mobility is for any adnexal masses to differentiate from
Right.
subserous fibroid from the weight. Here you should say whether it is mobile or not. Why is it important, mobility?
In fixed at
Any
PIT
fixed-
endometriosis, it will be fixed mass.
Pardon?
Ma'am, in chronic PID associated
endometriosis or malignancies, it could be
it
fixed.
will be fixed, ma'am.
Okay, anything else? Why you want to know whether it is mobile or fixed or restricted mobility? Why? When you examine, you have to decide upon, see,
The management of
what do you want to know?
whether we could
Why?
proceed with myomectomy or
Myomectomy. So mobility has nothing to do with myomectomy, right? So when it is mobile, you can go ahead with, laparoscopy. Okay, you don't expect, that means there are no, additions. You don't expect additions. Okay, that means you can go ahead with your laparoscopic procedures and you need to anticipate what complication you can expect, right?
Yes.
So that is very important whenever you are planning for a surgery, that mobility of uterus is very important, okay, to assess. Okay, that is important. Tenderness, have you mentioned? It is,
Yes,
you have
ma'am.
mentioned only formicial tenderness. What about uterine tenderness? Why is it important?
Any case of any uterine collections, like
How will be the adenomyotic uterus feel?
Will be adenomyosis
Please
tenderness will be there.
remember that fibroid. There are two main important things that differentiates, okay, between a fibroid and adenomyosis are consistency. Okay, so whenever you examine, just put your mind into it. Consistency, when it is firm, it is usually a fibroid. Okay, when it is hard, usually adenomyotic uterus will be hard. Have you ever felt you would do no cut section after the surgery? You will try to cut the specimen. When you cut, you will find it difficult to cut an adenomyotic uterus rather than a fibroid uterus unless there is any calcific degeneration. Okay, so based on the feel, one you can say whether it is adenomyotic uterus, maybe an associated adenomyosis also. And uterus will be typically tender in adenomyosis. These 2 points, clinically important points, you can vary without even ultrasound. You can say whether it is dealing with a fibroid or an adenomyosis. Okay, so tenderness of the uterus and what is the feel, whether it is firm or firm to hard. Firm to hard will be your adenomyotic uterus. Okay, so these are all important practical points that you can make out during examination and mobility to plan. Okay, rule out any adhesions. Okay, no cervical motion tenderness. Why did you ask for cervical motion tenderness? Do you expect anything? See, this transmitted mobility, cervical motion tenderness, why?
Again,
transmitted mobility is mainly to differentiate it from any ovarian adnexal mass from.
So we are not dealing with adnexal masses. You have written as fornicel free, right? So transmitted mobility may not be applicable for this case. Okay. And cervical motion tenderness also. Okay. So may not in this case problem. Okay. So usually where do you get cervical motion tenderness?
Mostly in pelvic inflammatory disease.
Okay. One more thing.
And endometriosis.
endometriosis, ma'am.
Endometriosis, or what is that? Acute and subacute condition. Ectopic pregnancy.
Pregnancies.
Okay, any mass? So leave alone this case. Some subacute ectopic pregnancy. Okay, in that case also there will be some cervical motion. So 2 conditions with cervical motion tenderness is, one is pelvic inflammatory disease and the other one is ectopic pregnancy. So other than that, you will not mention this generally unless you have your history says that it could be a thing. Okay. Yeah. Next slide, please.
Yes. Provisional diagnosis: Mrs. X, 40-year-old, para to life to, previous to normal vaginal deliveries, last childbirth 14 years, sterilized, presented with heavy menstrual bleeding for 1 year and abdominal distension for 6 months, associated with dizziness and easy fatigability, clinically pallor, and bimanual examination shows uterus irregularly enlarged to 16-week size. A case of provisional case of abdominal uterine bleeding, probably leiomyoma with associated anemia, for further evaluation and management.
Did you put it as leiomyoma? I still can say it is adenomyosis, right?
Yes.
So how did you differentiate these two?
Uterus enlarged
The
and with the
uniform
You never wrote anything, right? So you have
Irregular.
just written as you can offer differential diagnosis if you want. My first differential diagnosis is fibroid uterus. See, by examination, because your examination has never been told that whether it is regularly enlarged or irregular.
regularly.
In that case, maybe it's a second diagnosis. You can put it as adenomyosis, but then you can put it as leiomyoma provided you have other, because dysmenorrhea and heavy menstrual, both things are there, right?
The adenomyosis, it's usually only up to 14 week size of
Not
uterus.
necessarily. Not necessarily. Have you not seen bigger size uterus? We have seen even 18 weeks, 20 week size, only adenomyosis. That's an exception, but okay. So, because you have put it as just enlarged uterus, so that's why. Okay.
Okay.
Fine. Okay, next.
Investigations, investigations to be done, general investigations, complete blood count, peripheral smear, urine function test, liver function test, blood sugars, and urine complete protein urine, X-ray chest, ECG, echo, blood grouping and typing, and serology. And other investigations to be done are ultrasound and 3D transvaginal USG abdomen. Sorry.
Why you have put every other special investigations? You can't tell like this.
Yes.
This is not the way, right?
Yes.
So first, initially, you will do only complete blood count, right? Rule out anemia, and then confirm the diagnosis. Okay, only for that, what you want?
Ultrasound.
Ultrasound. Then why again? You have put everything. Usually, only UG will do like this, no? They will put all known investigations into one paper, right? It should not be like that. Okay, are we doing TVS, Doppler, MRI, everything for all patients?
No.
And then why did you tell that?
What you are doing in your clinic? That you
First,
say.
initially, this at this stage, what generally we do?
You do ultrasound.
Yeah. First thing, to confirm the diagnosis is your ultrasound. Okay. And because she's anemic, you will do a CBC. Okay. It's fine. So then, when you plan the management, then you can go ahead and do all other fine. So ultrasound, what ultrasound you want to do?
For a large fibroid, a transabdominal ultrasound. Here a transabdominal ultrasound.
So
Other things you can identify by doing an ultrasound.
Yes.
So what are you looking at the ultrasound?
Size.
The uterus, the size of the mass.
Location and position of the
fibroid. Confirm the diagnosis whether it is fibroid. Okay.
And the adnexus.
Endometrium thickness.
So go stepwise. Okay. First, so when you look at the mass, so what are the masses? How many? If it is a fibroid,
you have to look for the size,
location.
Location.
Okay, size, location,
number. Number of the fibroids. And
endometrium. And then you look at the ovaries. Okay. And the tubes. Yeah, if it is a hydrosulfings, maybe sterilization, that is quite commonly seen. Yes. Okay. So how do you classify the fibroids?
Fibroids can be classified by.
You want that or not? Do you want that information?
Yes, ma'am.
Why?
For the management also, ma'am.
What management?
Mom, you can go for the type, according to PIGO classification, you can classify the fibroids. Type 0, the type 1, that is intracavitary peduncle one, type 0. 0,
Type 0.
Zero
Cavitary
peduncle in intracavitary. Type 1, it is submucosal fibroid, less than 50% of myometrium. Ma'am. Type 2, it is more than submucosal fibroid, more than 50% myometrium. Type 3, it is intramural but contacts with the endometrium. Type 4, it is intramural. Type 5, subserosal,
with less
more than 50% myometrium. Next is subserosal, more than less than 50% myometrium. Ma'am. Next 7 is pedunculated subserosal. Ma'am.
8 is cervical fibroid.
Others,
Cervical.
cervical and broad ligament parasitic fibroids. Ma'am.
Why do you want to know this?
Ma'am, managing, either it is, we can go for medical management or surgical management. If it is medical, we can go for hysteroscopic myomectomy or
Medical, I don't get it.
Ma'am, if it is submucous fibroids, we can go with hysteroscopic
Hysteroscopic
myomectomy, hysteroscopic removal of fibroids, ma'am, based on the types. Ma'am.
Again, it is based on the step W classification of fibroids.
And okay, so if why do you want to know the number of fibroids?
If it is multiple fibroid, medical management, better go for surgical.
So in medical management, in whom will you suggest expected management, medical management, and surgical management? So for who you will suggest each?
Based on the age and parity, young age group. Ma'am. Those who wants for the infertility treatment, they can go for the medical management first. Ma'am.
Medical management. So when there are fertility preservation.
Yes, ma'am.
So for them, medical management. Is that so? So what is that medical management? What does it include?
From controlling any abnormal bleeding, we have to control the bleeding.
Then you have to reduce the size of the fibroid.
So will it reduce the size of the fibroid?
Yes. Yes, ma'am.
Yes, from some drugs.
Which one?
General Channelax can
General
be given for
Channelax,
reducing.
Okay, when you're giving a general channel, are they going to conceive?
No.
Then will you opt for medical management for them?
For them, no. For fertility preservation, we mainly go for myomectomy.
Yeah.
If it is intending the
Starting the endometrial cavity.
we go for
Okay. So there are certain indications
Indications.
when you will do myomectomy also, right? So
Yes.
so as we are talking about medical management, okay, let's talk about what are the medical management that are available. How do you basically classify that?
non-hormonal and hormonal.
Okay.
Non-hormonal are mainly to control the bleeding. We could use tranexamic acid.
500 mg TDS or QID for 3 to 5 days for 3 months can be given for 3 cycles. Then NSAIDs can be
Is there
given.
anything like that? Any limit? But
No.
tranexamicus, if they're comfortable there with that, they can use it. What is the precaution you will take?
To rule out thromboembolic manifestations.
Yeah, so that is so you need to ask them to be mobile and drink a lot of water and report if they have any symptoms such as you of that you need to tell. Okay, always tell the patient tranexamic acid, and it can produce gastritis as well. Okay, so to be taken after food along with, if necessary, anti histamines like ranitidine or like pantoprazole, whatever it is. Okay, so tranexamic acid, we do use it frequently, but then all these things have to be told to the patient. Okay. 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 Next. So does it reduces the bleeding alone? Okay. That does only the control of the symptoms and not the size of the fiber. Okay. Okay. Next is, so do you think that in this case will that help?
Reducing menstrual loss, we can give.
We can give acid.
So is it a definitive treatment? Do you think that
No,
it will suit?
we have to correct the anemia also.
Yeah.
And
okay.
Then we have to go for other hormonal treatments if the patient doesn't want surgery.
Okay, so what other medical management?
Combined oral pills can
Combined
be
oral
given,
pills.
ma'am.
Then selective progesterone estrogen receptor modulators and progesterone receptor modulators
What
used.
is that?
Selective estrogen modulator is obilaxacin, ma'am, Centroman, 60 mg twice weekly for 3 months, or later 60 mg weekly once for next 3 months can be given, ma'am. Selective progesterone modulator, ulipristal can be given, ma'am, 5 mg for daily, 5 mg daily for 3 to 6 months, ma'am.
So is it, are we giving it?
Ma'am, now because of liver,
It is
it's still not.
it is
So,
not routinely
but,
used.
so it cannot be used for a long-term
Long
basis,
time.
Long
right?
term.
Yes.
For
Yes.
whom, what is the indication? Still we use it for some women, right?
LFT to be monitored, ma'am.
Yeah, that is there. With
LFT.
monitoring, we can give. Okay. For whom you will give?
நாளைக்கு மதியமே கிளம்பிடுவோம் நாங்க பையன் பார்த்துட்டு அப்படியே
I want
கிளம்பிடுவோம்
to go for medical.
So,
மண்டே மார்னிங்
is it for medical management? See, when you're waiting for
Before
any
going to
surgical
medical,
management, when you
or
want to
reducing the
postpone
size
for
of
correction of
size.
anemia or something. Okay.
Yes, ma'am.
So for in that case, for
Waiting
maybe
period,
for 3 cycles, you can give ulipristal. And then once you stop, what is the thing? Once you stop again,
recurrent.
it's not recurrence, the size, it comes back to
Size.
its original size.
Original size.
Okay, so that is the thing.
Yeah.
Okay. So what other medical management? Yeah, combined pills. What is the side effect?
Combined pills.
Yeah.
Headache, breast tenderness, and
So which is more important? See, that is all there. Thromboembolic. See, like tranexamic acid, the same thing. VT risk is there. Okay, you have to assess and then give. And again, it is going to cause. It is only for symptom control. Okay, it does not reduce the size of the fibroid. Okay, what other option is there?
ZNRH,
Anything
antiprogesterone.
else before that? You should be telling about that.
Levonorgestrel.
May not be, yeah, levonorgestrel, IUD, right?
Yes, ma'am.
So that is an option, but may not be in this patient. Why?
Endometrial cavity distortion will be there, ma'am. So it's difficult to pass.
Yeah, so submucous fibroid, yes. And anything else?
Adenomyosis you can put.
Yeah. So if the fibroid is say 3 centimeters intramural fibroid.
Yes, ma'am.
Yes, you can
Yes.
give.
Yes,
Say for 5 centimeters, 6 centimeters, can you give?
it will be difficult.
Difficult.
Because
Size is high, so
the expulsion rate is high when the size of the fibroid is more than 3 centimeters. Okay. So the criteria for LNG IUS is again it's going to give a symptom control. It does not reduce the size of the fibroid. Okay. So for 3 centimeters fibroid, which is not into the cavity. Okay, the upper limit is 3 centimeters. That is what evidence says. Okay. Because more than that, the expulsion rate is more. That is it. Okay. So LNGIUS can be a choice for some women whose the size of the fibroid is less than 3 centimeters. Okay.
Yes.
So, okay. So next is progesterone. Again, only pills can be given.
Yes.
Okay, progesterone both for contraception as well as this. Again, symptomatic relief. Okay. So you can give tranexamic acid, progesterone only pill, combined pills. Yes, thromboembolic manifestations is there because they need to be monitored and wait about the risk and then given. And then you can give LNGIUS. And ulipristal, as you mentioned, can be given on a temporary basis just to gain time or treat anemia. Okay. So yeah, I can talk about the GnRH analogs. Yeah.
Yes, ma'am. Injection
Leuprolide or
3.75 mg. 30 units are intramuscularly. Every month can be put for 3 to
every month or what? We have
3.75 every month. If it is
7.25, it is
3 months old.
So how long can you give? What are the indications? What are the side effects? Indications.
Indications you can waiting period for reducing the size of the fibroid.
Okay. When will you give? So waiting. Okay.
For
Side
anemia
effect
to be corrected.
till anemia to be corrected. We
Corrected, we have to give for side effect could be amenorrhea.
Ma'am, side effects, patient osteoporosis, the plane of cleavage will not be will be distorted, ma'am, if you are going for laparoscopic myomectomy after taking GLRH, ma'am.
Or else if they say if it is 20 week size
And small
fibroid.
fibroids are
If it is 20 weeks fibroid, okay,
the size.
you give GnRH, what can
Yes,
happen?
ma'am.
It can reduce the size, right?
Size,
So
yes,
you
ma'am.
can, if
So
you
you
are
can
planning for a
think, plan.
hysterectomy, okay, so the size will come down. It will be easy for you to do a hysterectomy, right? And if
Yes,
you may have to do give a midline incision if at all you're going for an abdominal hysterectomy, then you can put very well put as SPT and then so you can it will change the size of the root of the procedure as well as the size of the incision or type of the incision as well. Okay. So GNRH, you need to know the indications, what are the benefits of giving it, when you will give, and what is the purpose you're going to give. Okay, it's not just a waiting period alone. Okay, around the perimenopausal age
One more
group
thing is
also.
when the case, when it is a multiple fibroids, seedling fibroids will disappear once you give a GNRH agonist. You'll miss when you're doing a myomectomy. So
Now,
yes,
the
large
advantage is
fibroid.
that, what are the disadvantages? That is what Madam is telling. If the disadvantage is, as Madam told, so the size will reduce, so you might miss during myomectomy. And as you mentioned, the plane also can be difficult in this section. Okay. But there are advantages. Yes, we go ahead and give, but these are the advantages. And
In
you
a
should
very
talk
large
about.
fibroid, definitely it is useful.
yes.
And so what you need to give, how long will you give?
For maximum of 1 year, we can give.
1 year? Is it so?
1 year,
6 months.
it's very
1 year.
long.
It is always 6 months, 6 months, 6 months. Please don't ever mention beyond 6 months. Okay. So you need to give what problems you anticipate.
Osteoporosis will be there.
They will go in for an artificial
Unless if it
menopause.
is more than 6 months, then you can anticipate this bone loss. Okay. Until 6 months, yes, you can give. So to prevent the symptoms, what can you give?
Add-back therapy, ma'am.
Yeah, add-back therapy. So that you need to talk. What is the difference? What is the other drug you were talking about?
The
The other drug. One is GnRH analog. The other one is?
GnRH antagonist.
Okay, what is that? Antagonist. Now we keep
Elagolix.
talking about it.
Elagolix
Elagolix
and
and yeah.
elagolix.
What is it? Yeah. How do you give that?
Elagolix 150 mg, ma'am. 150 mg, 1 OD you can give for 3 months, ma'am.
It's again 3 months, is it?
3 to 6 months.
Be specific, doctor. It should be given for 6 months.
So there are certain advantages. You have to compare GnRH analogs and antagonists. Okay.
Yes, ma'am.
The difference is that when you give GnRH analogs, there will be flare effect initially. Okay. So that can cause exacerbation of the symptoms. Okay. Heavy menstrual bleeding and all this stuff. Okay. So that is the disorder. To overcome this only, we have this antagonist, and the one more advantage is it is orally effective. Okay. And they have found it that it doesn't come as actually the approved form is along with the combined hormones, right? Estradiol and norethindrone. Okay, only that is approved. Again, you have this bone loss and all. Okay, so when it is given beyond 2 years, studies have shown that they are going in for bone loss, permanent bone loss. Okay, so because we are giving, it is approved to be given along with estradiol and norethindrone only. So this can be given for a prolonged time. Okay, because for endometriosis, we do use it for other conditions as well, right? We have especially endometriosis, right? Endometriosis or adenomyosis or fibroid. These are the conditions where you use Levans, right? So you can use beyond 6 months also, studies have shown, maybe maximum up to 2 years, not beyond that. No, maximum I'm telling. So generally, because once you stop it again, so though it reduces the size by 50%, symptom control and everything is there. But once you stop it, again, similar to whatever medical management, it's going to come back to its original size. Okay. So generally, we don't use it for a longer time. So only to gain time for some other permanent solution or definitive treatment, we always give that. Okay. So that is the advantage, and you should know the difference between GnRH analog and antags. Okay. So anyway, this is an inbuilt add-back therapy is there. For that, you need to give separately. That's it. That is the difference. But somehow if you're giving elagolics separately, okay,
Yes,
you again have to give add-back therapy. Okay, it is available as a combination therapy only. Okay, antagonist is not given separately. Okay. Okay. There is no flare effect here. That is one more advantage. Okay, directly within say a couple of days, it will that flare effect in GnRH channel will be about 1 to 2 weeks. So after that only your FSH suppression will happen, and then the hormones will come down. Okay, here the effect will be within 3 days and antagonist. Okay.
yes.
Okay. So these are all about the medical management. Do you think your patient will be suitable for medical management?
No, ma'am.
We can't say that, but anyway, we have to discuss. You have to discuss with the patient that these are all available, because she may decide, no, you may not directly go in for surgery right away. She may have some personal issues. She may have to come back. In that case, you may have to give this medical treatment as. Okay. Okay. Going on to the surgical management, yes.
Yes, ma'am.
Surgical management, there are different options from myomectomy and other
Laparoscopy, hysterectomy, or
that's all. Myomectomy, hysterectomy.
magnetic MR
அதுக்கு முன்னாடி ஒண்ணு பண்றோமேப்பா.
artery embolization.
அத விட்டுறீங்களே, why?
Intervention, uterine artery embolization.
Okay, that is more commoner than your MR focused or ultrasound focused HIFU and all. Okay. Okay. So you compare this, no? You have 3 options, right?
Yes, ma'am.
Uterine artery embolization, myomectomy, and hysterectomy. Let us leave this MR focus because this is still under research, and we are not doing it because it's quite costly. Okay. But let's talk about it at the end. Okay. So what about uterine? What we do? Okay, you talk about myomectomy. Yeah. What are the uterine preserving surgeries? Options are?
Uterine artery embolization and myomectomy.
Okay. Okay, fine. So, okay, first talk about myomectomy. Okay. What are the routes?
Myomectomy, hysteroscopic and
Open or laparoscopic.
Right? Open myomectomy you don't do.
open and laparoscopic.
So that is also there. There is a limit for anything, right?
Yes,
A big anything more than 10 centimeter or multiple fibroids. Okay, you will not do that in laparoscopy. Why? You have say 10 fibroids. Okay, she's a young female. You're planning for myomectomy. Okay, 10 fibroids. Okay, but about say 14 to 16 weeks fibroid. Will you do open or what?
open myomectomy only.
Why?
Ma'am, large fibroid that oscillating, it will be difficult, ma'am.
Necessary once morcellation இருந்துச்சுன்னா பெருசா இருந்தாலும் சின்னதா இருந்தாலும் you can morcellate. You're going to use morcellator, right? Yeah, that's there. So time consumption. Okay, you will take a longer time when compared to open myomectomy. Lap myomectomy takes a longer time. Yes.
Yes, ma'am.
So that is the reason why you don't prefer laparoscopic myomectomy. You go in for open myomectomy. Otherwise, there is no difference, right? So both are equally good. Your outcome will be equally good. That is not a problem. But the time taken in a laparoscopic myomectomy will be more. So that is the reason why they have limited the number of fibroids. Why you should not do more than 4 or 5 fibroids. Okay. Any other route? Hysteroscopic. When do you prefer doing a hysteroscopic myomectomy?
For type 0 and type 1 submucosal fibroids will go for.
That's it. So 7 centimeter submucous fibroid is there.
Ma'am, we can do it in a 2 setting,
Two
ma'am.
setting,
If
ma'am.
less than 5, we can.
According to step ladder classification, until a score of 6 we
Step
can
W, right?
WS. Step W classification, score of 0 to 4, it is a low complex hysteroscopic myomectomy can be done. For a score of 5 and 6, it is a high complex, two sitting hysterectomy resection of myomas.
What is the other name for step W?
Class mark.
Last mark.
Last mark.
Last mark.
You know that, please know about all those stuff. Okay, what is step W, what are the components and everything. Okay,
Yes.
so hysteroscopic myomectomy, yeah, what are the advantages and disadvantages?
Advantages, it is a minimally invasive.
Minimal invasive,
Minimal
ma'am.
invasive.
Shorter hospital stay.
Easy,
Yeah.
faster recovery.
Post-operative pain will be
Okay.
less, ma'am.
Disadvantages are
So only if it is bigger, then
bigger
other
size.
side effects are there, no? Water intoxication and all the stuff are there. Otherwise, it's if it is going to be a small one, yes, it's good. Okay. So maybe in cardiac patients, you may not be able to do because that water intoxication will be there. So there are certain criteria. Anesthetic problems are also there that you need to always keep in mind. Okay. So the time limit is there and the input, output, and everything has to be monitored. Okay. So that's the reason why we don't do it in a single sitting. Okay. Okay. So next, going ahead with the myomectomy, lap myomectomy or whatever it is. Yes.
Before doing myomectomy, we have to counsel the patient, ma'am. Proper counseling to be given, as it is recurrence chances of recurrence will be there, and it is it cause intractable bleeding, so chances of hysterectomy will be there.
What is the percentage?
20.
Have you ever seen ending up in hysterectomy? Myomectomy? Ending up in hysterectomy? That means the chances are less. It's a rare complication, less than 1%. But still, yes, of course, you have to get a consent for hysterectomy, but you should know the percentage. Less than 1% only. Okay, but we should. So what are the preparations?
You have to reserve the 2 or 3 units of blood, ma'am, before proceeding for the myomectomy. And if you're going for the infertility treatment, patient to be evaluated and other causes of miscarriages and the reasons to be evaluated, ma'am. Husband's semen analysis also to be done before proceeding for infertility myomectomy. Proper consent.
Yeah, consent with all other for everything, like hemorrhage or damage to adjacent structures and recurrence. What is the recurrence rate?
2 to 3%.
Recurrence mean what?
Again, they will come with the complaint.
Yeah. You should know the percentage. It is about 15 to 30% somewhere. Okay. Around 15 to 30% in 5 years. Okay. So these two percentages you need to remember in myomectomy. So less than 1% hysterectomy and 15 to say around 30% in the next 5 years. That you need to tell. Okay. Because if you don't tell what the patient will say, you did not do that surgery properly. You have left behind the fibroids. Okay. So that is very important. Okay. And yeah, what precautions say you are planning for a myomectomy? So what you'll do? Intraoperatively.
Intraoperative to reduce the blood incision, ma'am.
Yeah, laparoscopic. Okay, you're doing it for whatever it is. What type of incision you'll make?
Vertical incision, ma'am.
Okay. Why not posterior?
Ma'am, additions will be there.
Yeah, more common. But if you have to remove it, then you have to, unless it is essential, you always prefer an anterior incision. Yeah, fine. Next.
To prevent the blood loss, we can use vasopressin.
So before the surgery, you should be prepared with a vasopressin. Right? How much you do?
20 units in 200 ml NS, ma'am. It should be you have to inform the anesthetist before giving the drug. Yeah, you can inject in the myome.
Biometry.
Yeah, myometry of the fibroid. Okay, fine. So it causes a temporary vasoconstriction.
Vasoconstriction.
That will be there. Okay. So because that's very important, you have to keep monitoring the patient. Okay, sudden bradycardia and everything can happen. We have seen such patients. So such a wonderful drug, but then you should be prepared. Whenever you're giving a drug, you should be prepared to face the consequences. So what to do if that occurs? So you should be ready for that also. Okay, because we consultant are responsible for the patient. Though we inform the anesthetic, we also should know what complication will happen if we give the drug and how to manage that. Okay, so you should know whether everything is going on right or not. Okay. Okay. So that is about vasop. Any other way of
Bone is
reducing the blood loss?
bone is clamp, myomectomy clamp can be
Yeah.
applied.
Okay. Anything else? You don't have clamp?
Rubber catheter, mom, you can put in the.
What rubber catheter? What is handy?
Column.
It's very handy here.
Catheters, ma'am.
Hmm?
Only catheters.
Only
ma'am.
Yeah, catheter or your infant feeding tube, the smaller one. You can use it. Yeah, okay. So what will you do if you put a catheter? I mean, your tourniquet. You call it as tourniquet, right? Yeah.
Tourniquet, we have,
Okay. You will leave it like that or what?
you have to
Ma'am,
maintain the
20
time.
minutes,
20
you
minutes
have
tourniquet time.
because
So
of
you
the
need
release.
to release in between. Okay, that is there. But anything else? Anything else you have? If you are doing it like laparoscopy. Okay. Any temporary uterine artery? That shoelace technique you would have seen,
Yes.
no? You would have attended some conferences, right? Shoelace
Yes.
technique, you just put in a tie over the uterine artery, and then once you have done with it, you just release that like a shoelace. No? You release that, okay, in the uterine. So that you need uterine artery temporary ligation. You can do. Okay, that you can release it up. So that we are doing it late, recently. Okay, many surgeons are familiar with that. So to reduce the bleeding, you should talk about the vasopressin, the tourniquet, and the uterine artery ligation, your shoelace technique. Okay, so temporarily you are ligating, and then you can release that suture. That is what. Okay, so you talked about the incision. You should be rattling it, no? One single incision through which we do go in for tunneling and remove as many fibroids as possible to avoid many cuts over the uterus, and that reduces the what? Because anyway, most of the time you're going to do it for fertility preservation, right? So that case, you try to reduce the number of incisions. Okay, now by doing that, you're preserving the myometrium, also avoiding additions. Okay, so because 60 to 80%, the addition rate is about 60 to 80%. Okay, for myomectomy. Okay, so any other methods to control the bleeding? What other precautions? So you have to be quick enough to complete the procedure. Okay, so you have to suture the cavity. Myomectomy. After you're doing myomectomy, what you will do?
Baseball switch.
Yeah, baseball suture is was the serosa, the upper layer. Tier of sutures.
2 to 3 layers.
2 to 3 layers you are going to suture it, because if the cavity is big, okay, single suture, it will not be sufficient. So you have to take tier of sutures to make sure that you close the cavity. Because any cavity that is left behind will be, there is a chance of hematoma. So that hematoma will lead on to secondary infection. That infection will lead on to the weakening of the myomectomy scar. So that is where hemostasis is an important issue that you need to address. So closing that cavity is very important. Okay. So that is that will help you, because we are, as you know, we are doing it for fertility preservation. Your scar should be very strong. Okay. So this is that infection only leads on to scar weakening. Fine. Okay. Anything about myomectomy? Yeah. So after myomectomy, what do you expect?
Postoperative care.
Post-operatively, many a times they will have fever. Okay, have you observed? So post-myomectomy fever is quite common in the 24 to 48 days. Immediately, not later on. Okay, immediately they can have fever. Okay, post-myomectomy. So after how long they can conceive? That will be the next question, right?
They should wait for 3 months.
3 to 6 months.
6
Okay.
months.
There's no studies, but then generally that is what they suggest, at least 3 to 6
Six
months for the scar to be. Because cesarean itself, we say it's almost similar to that, right? Cesarean,
Same.
what we say, right? At least 18 months. Yeah, at least
18
6 months. At least 6 months. Okay, you should wait. Okay, hysteroscopic, then laparoscopic, and then okay, myomectomy. Then going on to uterine embolization. Yeah.
Uterine artery, through the femoral catheter, we have to introduce the
It is a, yeah. It is
Intervention.
done under anesthesia. What anesthesia?
General,
Mhm.
uh,
It is only local here, local infiltration. Okay, local infiltration. That is the advantage. Whoever is not fit for any of your anesthesia, so that is the advantage of going in for uterine artery embolization. Okay, under local infiltration. Okay, will be done by interventional radiologist. Okay, okay, femoral artery catheterization. Then
and they introducing polyvinyl particles into the uterine vessels, ma'am, so that it blocks the vessel and cut off the blood supply to the myoma.
okay. So you're going to embolize the feeding artery,
feeding
right?
artery.
Feeding artery. Okay. So what are the prerequisites for this? What are the contraindications?
I mean, the patients who desire for fertility, we should not do, ma'am, because
Right?
So, they will reduce the fertility of
Right.
fertility by decreasing the blood supply to the endometrium and thinning of the endometrium.
Okay. If they conceive?
Hmm?
If they conceive.
they conceive, they will result in miscarriage or
Miscarriage.
preterm labor.
Okay, miscarriage, preterm labor, then
Placental abruption.
abruption or what? Mainly placental accreta syndrome, placental abnormalities. Okay,
Yes.
and postpartum hemorrhage.
Hemorrhage.
Okay, these are the things. That's why you always take precautions. Okay, so whenever they are going in for uterine embolization, you should advise them what? Contraception.
Contraception.
So that because they should not become pregnant, right?
Right.
So that is very important. Okay, that may not be. They wouldn't have gone in for. I mean, they may not have planned for a pregnancy. It could be an accidental or an incidental pregnancy. To avoid that, please advise them contraception. That's very important. Okay. So, what are the other contraindications? Anything else?
Acute infection.
Yeah, acute infection, any pregnancy or fertility options. Yeah, that's right. And what are the complications?
Hematoma at the site of
Okay.
puncture, mom. Same post-embolization syndrome. Patient
What
will
is
be
it?
having fever, malaise, some constitutional symptoms will be there after the embolization, ma'am.
Right.
Because of the release of the particles entering into the perineum.
This because of the ischemia.
Ischemic,
Ischemia. Ischemic necrosis. So that
necrosis.
releases all those stuff. And severe pain they'll have. Ischemic pain. It's not a simple, like, don't think that this pain is better. Actually, you need to give them a very good level of analgesia. Maybe sometimes opiates also. Okay. So that is very important. So that's the reason the patient has to stay over there. Maybe they might require this analgesia for a couple of days. Okay. So though it is done under local anesthetist like infiltration, the post-operative period will be quite stormy like this. Okay, severe pain. Okay. So post-embolization syndrome. Then they will have what else they can have? What other complications? Oh, it is safe without any complication. What will you do for post-embolization syndrome?
Thromboprophylaxis.
Okay, that you need to assess and then do. That's a different thing. How do you treat post-embolization syndrome?
As a reassurance analgesics.
Analgesics and supportive care.
Yeah,
That is
hydration. Yeah, analgesia, antipyretics, and hydration. Because it is not, fever is not infective. It is just a release of those substances. But then when suddenly it is offensive, the discharge is offensive. What do you do? What do you anticipate?
Higher antibiotics.
So it means that she's going in for sepsis. Please remember that any foul smelling discharge, it means that because of the necrosis, there can be secondary infection. She can go in for infection and sepsis. Okay, please remember you need to know how to handle a woman with infection and sepsis. Okay, so if what you give antibiotics, but still she's not responding to treatment.
What will you do? Septic foci is there, no?
Yes,
You have to culture.
You have done culture, antibiotics you have given, sepsis bundle you have followed, sepsis 6 bundle, you should be knowing what it is, okay?
Yes.
You have to go for hysterectomy.
Okay, so that is very important when you get the consent. See, you are doing this procedure to preserve the uterus, right? But again, there is a risk of very rare risk of hysterectomy in case she develops severe infection. Okay, that is what the percentage again is less than 1%. That also you should know. Okay, is it a permanent solution?
No.
What happens to you should know, right? You should tell the patient, yeah, by doing this, you will, what they will expect, how much blood loss, what is the symptomatic relief they are going to have, and what about the fibroid. 2 things you should talk. Okay, one about the symptoms, next about the fibroid. So what will happen to the symptoms? What will happen to the fibroid?
Symptoms will reduce, mom, but size will be decreased.
Symptoms is reduced and they can go in for amenorrhea also.
Amenorrhea.
Okay, the success rate is about symptom that 80 to 90%. Okay. Next, fibroid.
Size will be decreased, mom, not it completely.
Yeah, it reduces the more than 50% reduction in the fibroid. Okay, Dr. Thirumavarada.
Yes, mom.
So the effect will be there for 5 years. Again, you should tell. Okay, many women, okay, around the same percentage you need to remember, around 15 to 20% may require re-intervention in 5 years. So that is the percentage you need to remember. 5 years, 15 to 20% here. In uterine embolism, they may have to go in for further management, either myomectomy or again uterine embolization or your hysterectomy. That consent should be there. Okay, it is not like just giving an option, okay, go ahead and do. They should know what to expect after doing an uterine artery embolization. One is how the procedure is done and how long they have to stay. What to expect after that. This post-embolization syndrome, whether it is normal. Yes, they can have this water discharge, white discharge, and passage of that expulsion. So if it is a submucous fibroid, they may have severe abdominal pain and they can expel something, no? That it can undergo necrosis and that can be expelled. That expulsion also you should tell them. Okay, so that what to expect. Okay, and you should tell them whether they have fever. Apart from this late infection will happen after that. Okay, sometimes later after 2 to 3 weeks. If after 2 to 3 weeks, if they come with fever and foul smelling discharge, then it points towards infection. When it is immediately after the embolization in the first week, so infection is not that common. Okay, so that is because of post-embolization syndrome and ischemia and necrosis. So that you need to know how to differentiate and tell the patient about the red flag signs. Okay, and the success rate and satisfaction and what happens to the fibroid and what hysterectomy is one of the known complications, but it is quite rare. That you should. Okay, so myomectomy also can end up in hysterectomy. Uterine artery also can end up in hysterectomy. The same percentage, less than 1%. And same recurrence rate or re-intervention rate, you call it as re-intervention rate, in the next 5 years will be around 15 to 20 to 30%. So these two percentages, if you remember, that's good. It's really important to talk to the patient. And other things you will talk, right? Okay. So here, if they're planning for conception, you cannot give them the option of uterine artery embolization. Okay, here, yes, you can give. That is fine. And what is the risk if they're planning to conceive in myomectomy? So what anticipate during pregnancy?
During antenatal period, there is chance of miscarriages, mom. In second trimester, there will be rupture of scar.
Necessarily second trimester, right? So,
More
how much percentage you should know? What is the percentage? So go find out today. Okay. So other percentages I have told. See, you should know the percentages now. Williams will tell all the tabular column will be there now. What will happen if it is a transverse incision, lower segment, LSCS scar, then midline scar, myomectomy scar, J-shaped scar, hysterotomy scar, low vertical. So all these percentages of each and every scar rupture during pregnancy, you should, okay, remember. Will you allow her for vaginal delivery?
No, ma'am.
It should be an elective cesarean.
Elective
Okay.
cesarean.
Especially when the incision, that's why we tell no, whenever the endometrial cavity is entered, okay, the rupture is more. Okay.
Sure.
But there are still controversies that are there, but the rupture is more. And one more thing is, you should, any myomectomy scar or any uterine scar like D and C, what problems you anticipate after pregnancy, that's very important. Scar due to, yeah. Apart from rupture, one more thing. You mentioned, no?
Abruption, placenta.
It is not abruption, it is placenta accreta spectrum. Okay, it is not abruption. Only if you have fibroid sitting inside the uterus, submucous fibroid, abruption you can say. Okay, that is another topic for discussion because she is not young. We are not discussing about that. There are a lot of questions like, what causes heavy menstrual bleeding in fibroid? What causes fertility, infertility? So all these are undergraduate questions. That's why I didn't go deep into it. Am I right? You will be able to answer now. Why heavy menstrual bleeding in fibroid? Why infertility in fibroid? These are all UG questions. That's why we didn't talk much about it. Okay. So these things are more important for your PG level. That doesn't mean that you should not concentrate on it. If you don't answer that, then that is a grave mistake. Okay. So here, what were we talking? Sorry, I just deviated.
Placenta accreta spectrum.
Yeah, placenta accreta. See, previously we thought that it is related to the number of cesarean deliveries, right? Number of, if it is previous 2 or 3 cesarean, then you anticipate placenta accreta syndrome. Nowadays, recently, what studies are showing it, any surgery in the uterus can be a fractional curettage or a suction evacuation or postpartum curettage or a manual removal of placenta or a myomectomy scar. Any scar in the uterus that is especially in the entering the endometrial cavity, okay, you should anticipate placenta accreta syndrome. Okay, so that is there. Okay, that is about what, okay, uterine embolization we finished, myomectomy finished, and hysterectomy. Yeah, tell me about hysterectomy.
Again, laparoscopic or open hysterectomy.
That's all.
One vaginal
Yeah, why can't vaginal hysterectomy? Please don't forget that. Okay, so we have seen, no, many are there. Usually as per book, it is up to 12 to 14 weeks. That is what is advisable to, but we have seen many doing even bigger size fibroid, 16 or 18 weeks fibroid by just morcellating from below, they can do it. But then for you, what you say is the limiting factor is 12 to 14 weeks, not more than that, right? Vaginal hysterectomy. Or you can do laparoscopic assisted vaginal hysterectomy. And then total lap hysterectomy also. Okay, but then morcellation, that is what is required. Okay, so when you are doing morcellation, what is advised? Even in myomectomy, lap myomectomy,
Contained
Endobag.
content or endo bag. That's very,
endobag.
very important. Okay. So otherwise, what can happen?
Any undiagnosed uterine sarcomas could go for dissemination.
Yeah.
Disease.
Upstage the disease. Okay.
Disease.
Upstage the disease. That's it. And even in the myoma, no, when you just when the morcellated segment or bit stays there inside the abdomen, that can grow somewhere. So rarely, leiomyomatomas, it's like that. Okay. Yeah, so that is there. Yeah, like that it can happen, but it's quite rare. But it is always recommended is in-bag morcellation. Okay. Okay. So what else? Hysterectomy. Okay. What is myolysis? Other options are there, but then we don't do it. We have myolysis, which can be done. Yes.
Laparoscopic myolysis also there, removing.
Just destroying the tissues. That's it. Heat coagulation or cryo, whatever it is. Okay, so that myolysis you need, but though we don't do, you should know about it. Okay. And coming to this HIFU, you are very much interested about it. What is HIFU?
Magnetic resonance, high intensity focused ultrasound.
High intensity focused ultrasound. What is the principle behind that?
Passing ultrasound waves over the producing the heat energy and destroying the
heat causes coagulation.
Heat coagulation. Okay. Heat coagulation. So what is the role of MR?
Visualization for the better visualization.
Yeah, guided. MR guided. So previously they were doing it under ultrasound guided. You remember? So previously you used to say ultrasound guided. You will do an ultrasound and you find out where the fibroid is and you will focus on. So why they have shifted this ultrasound guided, the same thing, okay? You shifted to MR guided. Okay, the reason is you have the some temperature measurement also in MR. Okay. So whenever the heat is increased, okay, we can actually visualize the heat coagulation that is happening and the changes that happen in the fibroid. You can see that in both ultrasound as well as the MR. Okay. So what they say is when the temperature is beyond that 80 degrees, okay, or when it reaches goes near the other structures, okay, it will switch off on its own. So that is a protective mechanism there, but it is not there in ultrasound. You cannot measure the temperature that is happening. The thermoregulation is not there. In ultrasound guided, MR guided has this advantage. Okay, so very clear visualization of this, and that is why whenever there is additions, you don't go in for MR. That is one contraindication. Okay, because a bubble is there and everything is there. No, when the heat can pass on, can extend to the next structures also. Okay, so that in MR, that is the MR guided focused ultrasound. It is a kind of ablation. It's an ablation therapy, thermal ablation. Okay. Okay, coming to this thermal ablation, just forgot to discuss about endometrial ablation.
Yes, ma'am.
Can you offer this to fibroid patient?
Ma'am, no, ma'am, you will not get a tissue for histopathology.
Right, when you put on an LNG IUS also or medical manager, you don't get the tissue, right? Yes, that is not the criteria that I am telling you. Okay, you're not getting endometrial ablation. You can do endometrial sampling and then proceed with the endometrial ablation. Okay. But there is a limitation for that. Again, the uterus should not be more than 10 weeks size. Okay, everything is uterine preservation. It is not a definitive treatment. Definitely, it is not going to address your fibroids. But definitely, heavy menstrual bleeding will be. Okay, whoever is wishing for this, okay, because it's a daycare procedure, it is a safe procedure, right? When compared to myomectomy and hysterectomy, the endometrial ablation, though we are not familiar, we don't use it in our scenario, our situation, right? But it can be offered as a choice, okay? When the uterine size is less than 10 week size, okay? and it is not a submucous fiber. Where the uterine cavity will be distorted, your balloon may not be fitting it. Okay, so in that case, but that is also a choice. Okay, like LNG, IUS, and every other medical management, endometrial ablation is also a choice for a specified group of patients with myeloma.
Right.
With proper counseling, that is what is important. Again, endometrial ablation says as uterine artery embolization or myomectomy. Again, they are temporary. It is not a definitive treatment, right? So here again, heavy menstrual bleeding, for which we are going to use this. Again, re-intervention after 5 years, or sometimes no, even earlier also they can have this resumption of the symptoms, reappearing of the heavy menstrual bleeding. Okay, so 80% satisfactory rate at around a year. So all these things you should know, how long it will take, what to expect. They can expect lower bleeding, and then amenorrhea also with endometrial ablation. So all these things you should explain to the patient. Even Mirena, you should tell what to expect, right? So it will take some time for that to settle, at least 3 months for the effect to be seen, okay? And until 3 months, maybe you can give her this tranexamic acid and all those stuff. And after 3 months, yeah, your symptoms will slowly settle down. It will protect your endometrium also. All these counseling will happen if it is not a big uterus. So I told you all those limitations are always there. You should know for which patient you should counsel this. You cannot offer everything for every other patient, right? For a 20 weeks fibroid or a 16 weeks fibroid, you cannot offer endometrial ablation. You cannot offer LNG-IUS. No medical management. Okay? So medical management, if you're giving, it's going to be temporary, all the things. So that's how you as a consultant or as a doctor, you should know what are the options available, and then you should cater them to that particular thing. Okay.
Yes.
Okay, anything else? Yeah, premature ovarian insufficiency also you should talk about in uterine artery embolization.
Yes.
Okay, in around 1 to 2% premature ovarian insufficiency can. Even after hysterectomy, early menopause can occur, right?
Yes,
Yes,
ma'am.
ma'am.
Even if you retain the ovaries. That's what I say. Okay, so that is also there. When you're performing, that will be there. Anything else? Yes.
So I
Dr.
think Madam
Padma?
has covered everything.
Oh,
I need to given a few things like you should know about the cervical fibroid, the broad ligament
yeah,
fibroid,
yeah.
and true and false,
Mm.
where you should be careful with the ureters.
Yes,
All this in a very huge fibroid also you need to the ureters are more
Stenting,
likely to
yeah,
be
as
injured.
Madam mentioned, yeah.
Okay. So
So-
all these minute things you should know as
Plan.
a postgraduate.
So planning is very important. So that fibroid mapping, even if you are doing a hysterectomy, you should know where exactly is the fibroid. If it's going to be a subserous fibroid in any of the right or left, any adnexal region side. So you should, as Manson mentioned, it is, you need to take care of the ureters and ureteric stenting. Okay, so ureteric stenting, yes, it is a controversial topic as such, but then we as a routine sometimes we use it. But taking care of ureter is very important when it is comes to a broad ligament fibroid or a pseudo broad ligament fibroid. What is the difference?
Ma'am, true broad ligament, it comes from the mesenchymal cells of the broad ligament, ma'am. False pseudo broad ligament, it comes from the lateral wall of the uterus and it pushes the ureter and the uterine vessel lateral, ma'am.
Grows in.
So ureter will, if the ureter is medial to the fibroid,
It's a true broad ligament.
okay, that is the major difference.
Suppose it's going to be a broad ligament fibroid, then you should know how to differentiate it from an ovarian mass and the fibroid. And by doing an bimanual pelvic examination, you should be able to say that group side is positive or not. Those things are basic.
See, I did not talk about all these basic things, like which is usually we teach for the UG students, right?
Yeah.
That is the reason I didn't touch. But then, as Madam mentioned,
So these
cervical
are the
fibroid.
small, minute things you should know. So some examiners might
Yeah.
ask the basic level. Okay, so all these things you should not leave. Already madam has told you that when you miss out these things, definitely it will be very difficult to clear
They-
the exams. Okay.
Definitely, they will start from the UG level, and then only they'll go ahead with the all these
Okay.
topics we have
And
discussed.
also
Okay?
fibroid in pregnancies. That is very important.
Yeah,
When you-
degeneration.
how do you encounter a fibroid during C-section? Whether routinely you do a myomectomy when you see a C-section. It's not routinely done. Only if it is going to be present in the incision site, you go about doing a myomectomy.
So you should know about all those degenerations here. I didn't talk about that.
Yeah.
Please, whatever we have not covered, that doesn't mean it is
You have to,
less important. No, that is assumed that you are knowing that.
Yes.
Okay, please read the basics first.
The problem
Okay, so that is the reason why we didn't touch that. You have to definitely know everything about what we have not talked about, and then come to this level.
settings இருக்குல்ல அத நாய்ஸ் ரிமூவ் இருக்கு.
Nithya, you're audible. Nithya, you're audible.
So Kanya, I think we can wind up. Is that okay?
Yes, Shanti, we can wind up.
Yeah, it's all.
Shanti, very nice. You have because I was traveling from all the way from Dharmaburi. Now only I'm entering Salem. So
okay.
I left your itself. So you have almost completed everything in detail as at the postgraduate level. Thank you so much. Thank you, Suganya.
Thank you so much. It was so nice. I think you also covered whatever points I have not covered. I think you have mentioned it. Yeah, because want of time, we have not covered that. Okay, if you have covered all these degenerations and all,
then it will take
we would not
2 hours
have come to this level. You understand?
Yeah, definitely.
So that is the reason why we skipped that part, the routine part. Okay? Okay. Okay, Sukanya.
Ma'am, I thank to judges, Dr. Padmapriya ma'am and Dr. Shanti ma'am for valuable presence in spite of their busy schedule. And it was a very wonderful discussion, ma'am, and a very informative one also. Many clinical points were discussed, ma'am. Very thank you, ma'am. And I also thank the present, Dr. Umiyal ma'am, Dr. Vijayalakshmi ma'am, and Dr. Bhuvaneshwari ma'am for giving the opportunity to conduct the today and to present the tidbits on hysteroscopy, madam. Thank you, ma'am. And I also thank the presenters for their presentation on the day's fibroid. Now let's move on to the quiz, ma'am.
Yeah, I should congratulate the presenters. They really good. They did a good job with fine corrections. That's it. Okay, I think definitely you can do better. Okay, all the best.
Thank you.
Thank you so much for the opportunity, Dr. Sukanya and other organizers, Madam Umiyal Madam and Bhuvaneshwari, my again one more batchmate, and other organizers as well. Thank you so much.
Congratulations to the presenters. Thank you, Suganya, Bhuvaneshwari. Both of you were my, my DGO class batchmates at IOG. It's nice to meet you. And Dr. Anbarasi, who introduced me, she was my student. Thank you so much for this opportunity.
Thank you.
I thank Padmapriya ma'am.
Yes, ma'am. Shall I launch the first question, ma'am?
Yes, Sahiti, we will move on to quiz.
Yes, ma'am. Each question will be given 30 seconds. So I request all the participants to submit the answers before 30 seconds. Nithya, ma'am, you can read the question.
Yeah, yes. First, what is the genetic molecular alteration most frequently identified in the pathogenesis of uterine leiomyomas? Options are BRCA1 mutation, MED12 gene mutation, TP53 deletion, HER2 amplification.
Last 5 seconds. Time, ma'am. Second question.
What is the mechanism of action of elagolix, a medical option approved for managing heavy menstrual bleeding associated with uterine fibroids? The options are selective progesterone receptor modulator, oral non-peptide GnRH antagonist, injectable long-acting GnRH agonist, and aromatase inhibitor.
Last 5 seconds. Time up. Third question.
According to the Figo classification system for uterine leiomyomas, a fibroid that is entirely intramural with no extension into either the endometrial cavity or the serosa is classified as type 2, type 3, or type 4. Three options.
Five more seconds. Time up. Fourth question.
What is the primary mechanism by which an intramural fibroid, Figo type 3 or type 4, that does not distort endometrial cavity may still contribute to recurrent pregnancy loss or infertility? Options are mechanical occlusion of both the infundibulopelvic ligaments, altered myometrial contractility and focal endometrial inflammation or dysregulated gene expression, total systemic depletion of progesterone due to high receptor expression in the tumor.
5 more seconds. Time up. Fifth question.
During a hysteroscopic resection of a Figo type 1 submucosal fibroid using a monopolar resectoscope, a non-conducting distension medium is used. At what fluid deficit threshold should the procedure be immediately halted to prevent severe hyponatremia and cerebral edema?
Time up. Sixth question.
When using a loop resectoscope to shave down a Figo type 2 submucosal fibroid, which safety principle must be strictly adhered to in order to prevent mechanical uterine perforation? Options are always cut moving the loop inward toward the resectoscope operator. Option B, push the loop outward toward the fundus while activating the electrosurgical current. Option 3, resect blindly, bleeding obscures the fluid to finish the procedure quickly. Option D, keep the fluid pressure at least 50 mm of mercury above the patient's mean arterial pressure.
5 more seconds. Time up. Seventh question.
Ulipristal acetate, a selective progesterone receptor modulator, was highly effective at controlling the bleeding and shrinking fibroids, but its clinical use has been severely restricted or suspended globally. What is the primary safety concern associated with UPA? Options are acute kidney injury requiring emergency dialysis, B, drug-induced liver injury progressing to acute liver failure, C, severe thromboembolism and deep vein thrombosis. Option D is high risk of transformation into endometrial carcinoma.
5 more seconds. Time up. Eighth question.
While preoperative treatment with the GnRH analog is highly effective for correcting anemia and reducing overall fibroid volume, what is a well-documented technical disadvantage encountered during a subsequent laparoscopic myomectomy? Option A, massive intraoperative pelvic hyperemia and increased capillary oozing. Option B, severe thinning of the uterine serosa causing spontaneous uterine rupture during gas insufflation. Option C, obliteration of the cleavage plane between the fibroid pseudocapsule and the normal myometrium. Option D, absolute resistance to the vasoconstrictive effects of the local vasopressin.
5 more seconds. Time up. 9th question.
During a technically challenging uterine artery embolization, the interventional radiologist notes that the fibroid continues to show significant contrast enhancement despite complete bilateral occlusion of the uterine arteries. What is the most common source of collateral arterial supply to a uterine fibroid? Option A, ovarian artery. Option B, internal pudendal artery. Option C, superior vesical artery. Option D, round ligament artery.
5 more seconds. Time up. Last question and 10th question.
Magnetic resonance guided focus ultrasound induces target tissue destruction primarily through ultrasound coagulative necrosis. What is the target peak temperature range required at the focal point during a single sonication to guarantee irreversible cellular death? Options are A, 37 degree to 42 degrees Celsius, B, 43 to 50 degrees Celsius, C, 55 to 65 degrees
5 more
Celsius,
seconds.
100 degrees.
Time up.
Sahiti, can you share Nitya's CV?
Yes, ma'am.
So in the meantime, Sahiti will consolidate the quiz marks and she will tell the winner at the end. Let us see the CV of Dr. Nitya. She's going to present tidbits about hysteroscopy. She has done her MBBS from Government Tanjavur Medical College in 2013, MSOG from Government Coimbatore Medical College in 2018, DNBOG in 2019, undergone laparoscopic training from MISTI Chennai in 2025, undergone 2 weeks ultrasound scan training, worked as assistant surgeon in Chengalpet Medical College from 18 to 2019, currently assistant professor in Government Peripheral Hospital Anna Nagar, memberships IMA membership and KOGS member. Over to Nitya for the hysteroscopy presentation.
Thank you, Dr. Sivini. Can you start the slide, Sahiti?
Okay, ma'am. Give me a second. Please inform next slide, ma'am, so that I'll change.
Yeah, yes. Okay. Good evening, respected professors, senior consultants, and my colleagues, and all the postgraduates. The topic of today is hysteroscopy. Next. What we will cover in this topic is the hysteroscopy, its history and the instrumentation, the clinical use, indication, contraindication, and the procedure, what are the findings and the complications. Next. So hysteroscopy, it is a use of an endoluminal endoscope, which is used to visualize the uterine cavity by negotiating the cervix. It serves as both diagnostic and therapeutic tool. So what are the procedures commonly performed, or it can be used for as a diagnostic and operative. It is minimally invasive and also for direct visualization. It is an image displayed on the live on the monitor in OT. Next. Next slide, please. A brief history. Actually, it was first introduced by Pantaleone in 1869. He visualized a polypoidal tumor within the uterus, and in 1925, the Rubin modified it, and by using a cystourethoscope to view the uterus, and for which water was used as the medium, then carbon dioxide. Now, then in 1960 and in 70, low viscosity and high viscosity fluids were invented as a distillation media. So the low viscosity fluids used to be saline and interlactate at 50 to 100 mm of mercury. And then in 1971, Histon and Mencken introduced 30% dextron in 10% glucose as a distillation medium. Nowadays, KOGS jelly has also been used as a distillation medium for diagnostic hysteroscopy. Next slide. Okay, the equipment and the instrumentation. Now, this picture shows the telescope, and each hysteroscope consists of an eyepiece, a barrel, and an objective lens. And normally, the most commonly used the degree of angulation is 0 degree, 12 to 15, and 25 to 30 degree. 0 degree lens gives a panoramic straight ahead view, and it is used for diagnostic purposes. Whereas angle lens are used to improve the visualization of the tuber ostia in an abnormally shaped uterine cavity. 12 to 15 degree scopes are used for therapeutic purposes, like for like mainly in operative hysteroscope, and while using resectoscope for ablation and for operative procedures. 25 degree scope is used mainly for tubal cannulation and for sterilization procedures through a hysteroscopic sterilization. Next slide. Two types of hysteroscopes are used. This rigid and flexible hysteroscope. Rigid hysteroscope is mainly used in the for operative procedure. Flexible hysteroscope is used for office hysteroscopy. Rigid hysteroscopy is used for inpatient and complex operating procedures. It has a diameter of 3 to 5 millimeter, and it's more durable and provides a superior image and resolution. Whereas flexible hysteroscope, it is used only for office hysteroscopy. Reflection of 120 to 160 degree. Better used for irregular shaped uteri and navigating around the intrauterine lesion. Next slide. Okay, the light source. The most commonly used light source are the halogen and the xenon. While the xenon generator produces white light, giving superior color, radiation, and intensity. LED is the most commonly used now. Newer alternative it is used. It does not run hot, and it carry a low risk of thermal burns. Generally the voltage used are 150 volts. 150 watts for diagnostic hysteroscope and 250 watts for therapeutic hysteroscopy. Now the cable length is about 180 to 300 centimeter, and the diameter of the cable is about 2.5 to 4.5 millimeter. You can show this is a picture cable connecting to xenon generator. Next slide. So the operative sheath. Diagnostic, there are two types of sheath, diagnostic and operative sheath. That is, the diagnostic sheath is the inner sheath. It is about 4 to 5 millimeter diameter, depending upon the telescope used. Diagnostic, it delivers a distillation media of 1 millimeter clearance between the inner wall and the telescope. I will show a video later of how a hysteroscope is being used. It is diagnostic sheath is fitted with a watertight seal lock. An operative sheath is about 7 to 10 millimeter in diameter. It is larger to accommodate the insulin distension media. It provides a working channel for insertion of operative instruments. Next slide. Distension media. Normally, the uterine wall should be distended at a pressure of about 40 millimeter of mercury for a clear view of the pathology. Two types of distension media are used. One is the gaseous and the liquid. Gaseous is carbon dioxide, mainly used for diagnostic or office hysteroscopy. Liquid is the high viscosity fluid, high viscosity and low viscosity fluid for selective procedures depending upon the energy source. Next slide. Okay, first is the carbon dioxide distension media. Why it works? Because it is colorless gas. It is ideal only for office hysteroscopy. But the major disadvantage is it is not used nowadays because it requires an insufflated, and also there is a risk of gas embolism. There is also no effective way to clear the blood or debris from the field, which limits the use in operative cases. Next slide. The most commonly used distension media are the fluids, that is low viscosity fluid, mainly normal saline and the lactated Ringer solution. It is used in diagnostic hysteroscopy as a first choice because of its easy availability and low cost. It is miscible with blood and can obscure the view. Excess absorption can lead to risk of pulmonary and cerebral edema. High viscosity fluids are used in case of operative procedures needing excellent optical clarity. That is, dextron 70 Histon is used, largely superseded by the modern low viscosity fluid management systems. Energy source decides the fluid choice. That is, depending upon the energy current, the fluid is used. Bipolar current uses normal saline as a destination media, and the monopolar current uses 1.5% glycine, a hypotonic solution, as a destination media. Next slide. The recently invented modern fluid management system is the Histomat. Histomat is an electronic suction irrigation pump. You can see the image there. It is an ideal fluid delivery system because both the inflow and the pressure are controlled automatically. The pressure maintained is 90 to 110 mm of mercury, and the flow rate is 200 ml per minute flow rate. The Systomat is mainly used to prevent the water intoxication post-operatively. Next slide. These are the instruments which are used. So this is the operative receptoscope. You can see it is assembled, and the basic three basic electrodes are being used. A ball, a barrel, and a cutting loop is being used. And the accessory instruments used are the alligator grasping forceps, biopsy forceps, scissors, and the mosulator. These are used in case of any while doing myomectomy, histoscopic myomectomy, or histoscopic polyp resection, etc. And monopolar and bipolar electrodes are both available. The new bipolar Versa point system allows saline as a destination media. What are the indications? There are both diagnostic and therapeutic indication. Diagnostic is the endocervical study in uterine malformations, Asherman syndrome, uterine septum. You can diagnose submucous and submucous fibroid and polyp, postmenopausal endometrial biopsy, misplaced IUCD, contraception assessment and phalloscopy, endometrial TB, abnormal uterine bleeding, endometrial cancer staging, and pre-invasive lesion from the endocervix. Next slide. Therapeutic indications are, we can do operative procedures like myomectomy, polypectomy, tubal cannulation, tubal sterilization, endometrial ablation using a roller ball, septal dissection, metroplasty, Asherman syndrome, and in retrieval of misplaced IUCD, and also for embryo and sperm insemination IVF, balloonoplasty. Next slide. Contraindications. Histoscopy should be avoided or deferred in these situations, mainly in acute pelvic infection, in pregnancy, allergy to glycine, scarred uterus, and uterus more than 14-week size, cervical stenosis, and active menstruation. Next slide. Preparation of the patient. So before performing histoscopy, 4 basic things are essential. First is the history and the examination. So detailed history and a complete examination, a physical examination is mandatory, or do a vaginal examination before the procedure. And timing, it should be done only in the proliferative phase of the menstrual cycle. And the informed consent should be obtained before the procedure, and a bimanual pelvic examination should be done versus the uterine size, shape, and the position. Next slide. Preoperative medical preparation. Cervical priming, it can be done in case of a stenosis cervix, or in case of a previous 2, 3 or 2 LSCS where the cervix is high up or cervix is closed. In such cases, 4 to 6 hours before the procedure, a vaginal misoprostol tablet is inserted to soften the cervix, allowing free insertion of histoscope. A 200 or 400 microgram per vagina can be kept in the posterior fornix. Then it also then before transcervical resection of the endometrium or myomectomy, starting 2 to 3 months in advance, injectable GnRH analog or danazol or progestin are given to reduce the vascularity and thinning of the and it should thin the endometrium so that the surgical field while performing histoscopy is improved. Anesthesia. Office histoscopy required, anesthesia is not required, whereas for rigid and flexible histoscopy or in diagnostic histoscopy, paracervical block or total intravenous anesthesia sedation is enough. For operative histoscopy, GA is essential. Next slide. Positioning and setup. So the position of the patient, the prerequisites are the bladder must be empty, and the patient should be in a supine and dorsal lithotomy position with the buttocks beyond the table edge and legs flexed. Vaginal examination should be performed. Assemble the histoscope and should white balance the camera. Attach the inflow and outflow lines. A trained assistant is assigned to monitor the fluid balance. Ensure no air bubbles remain in the tubing. And vaginoscopic approach is a common approach performed. Vagina should be distended, external was located, scope carefully inserted. Next slide. So this is a systematic examination of doing the histoscope is You should follow the cervical crypts to visualize the internal os. So we'll be first seeing the cervical canal, then you will negotiate the uterine cavity, then the internal os, then the right ostium, the fundus, the right lateral wall, then the left ostium, left lateral wall, and the posterior wall. This is the order by which the histoscope should be performed for diagnostic purposes. For the uterine cavity, you should note the size, shape, and contour throughout the sweep described above. Next slide. So this is a normal histoscopic view. The first picture demonstrates the cervical canal and the crypts. Second is the internal os, and the third is the fourth picture is the tubal ostium, and the last is the anterior wall, posterior wall, and lateral wall of the uterus. Normal endometrium. Next slide. The pathology on histoscopy. So we can the various pathologies which can be visualized in histoscopy are the cervical polyp is the first picture. Second is the Asherman's is the uterine septum. The thick white line is seen. Then third one is the adhesions. Fourth is the submucous fibroid, and E is the endometrial polyp. F is a tubular uterus. Next slide. And this is some of the common pictures which we have done in our hospital for histoscopy. This is our cervical endometrial area, and this is the submucosal fibroid and the polyps which is being diagnosed there. Next. This for second slide is the adenomyotic uterus to visualize through histoscopy. Next. So submucous fibroids can be classified based upon the Van Stryker's classification, and it grades the submucous myomas by how much of the tumor lies within the muscular wall. Type 0 lies entirely within the cavity, no intramural extension, and it is pedunculated. Type 1 is less than 50% of the intramural extension. Type 2 is a 50% or more, but generally up to type 0, 1, and 2 can be removed by histoscope. Next slide. Then this is the cesarean scar niche, that is recurrent bleeding from the lower segment scar. That this is a late complication of cesarean section. So that the bleeding from the recurrent from the cesarean section scar diverticulum can also be diagnosed by histoscopy, and it can also be treated and by resecting the fibrotic edge to stop the recurrent bleeding. So here, this is a HSG picture showing cesarean section scar diverticulum. Next slide. Then the complications. The intraoperative complications are intraoperative bleeding, raising the distension media pressure above the mean arterial pressure, compresses the uterine wall enough to stop bleeding. A bleeding vessel can also be coagulated directly with a 3 mm ball electrode. And distension media, the complications are cardiac arrhythmia from excessive gas absorption and gas embolism due to fluid media, anaphylactic reaction, pulmonary edema, and adult respiratory distress syndrome. Next slide. Acute fluid overload and late onset complications are the acute hyponatremic state. A fluid deficit of 500 ml or more should alert the surgeon to likely hyponatremia and hyposmolality, which can progress to cerebral edema and CNS abnormality. Close monitoring of the inflow and outflow prevents this. Late onset complications are the infections, pelvic inflammatory disease, vaginal discharge common after ablative procedure, usually self-limiting, and the adhesion formation. Next slide. So adhesion formation post-operatively can be prevented by a second look or third look hysteroscopic adhesiolysis, and barrier methods can also be given. Ceprafilm and amnion graft can be given as a barrier. Mechanical methods like IUD, Lippes loop, and Foley's balloon can be used. Hormonal treatment are estrogen, progesterone, and GnRH analogs. Then pharmacological agents, antibiotics, antihistaminics, and NSAIDs. So red flag finding is in the endometrial cancer, histoscopy allows direct visualization and targeted biopsy of suspicious endometrium. This is a picture showing irregular vascular friable endometrial surface, and this warrants immediate histologic sampling. So histoscopy helps in direct magnified view of the endometrial surface, guided targeted biopsy, not a blind sample, and it is used in endometrial cancer staging also. Next slide. The key takeaways are So the cystoscopy allows direct visualization. It is gives real-time direct access to the uterine cavity for both diagnosis and treatment. And the medium matters. The right distension medium depends upon the procedure and the energy source. So gas, low viscosity or high viscosity fluid. Generally, gas is not used. Only low viscosity or high viscosity fluids are used. So one should monitor the fluid balance. A deficit of more than 500 ml is a trigger to watch for hyponatremia and fluid overload complications. So if you know the red flags, they recognize submucous fibroid and the type scar niches and suspicious endometrium yearly. Next slide. This we can watch a video of hysteroscopy.
I think I cannot play.
Play okay, actually the slide. The video was very nice.
Sahit, is it possible to share the video?
Can you hear the audio, ma'am?
No, audio is not heard, but actually audio is there in that video. Okay, play the video. I will summarize.
Visualization and treatment of intrauterine pathology using a hysteroscope. Hysteroscopy can be either diagnostic or operative. In diagnostic hysteroscopy, the uterine cavity is visually inspected. In operative hysteroscopy, the uterine cavity is inspected and appropriate treatment performed. Ideally, a see and treat approach involving both diagnostic and operative hysteroscopy is preferred. Indications for hysteroscopy include assessment of abnormal uterine bleeding, infertility, recurrent miscarriage, retained products of conception, inadequate or difficult office sampling, removal of foreign body, and abnormal endometrial thickness. The hysteroscope may be rigid or flexible. The rigid type is more commonly used. A rigid hysteroscope includes the following components: endoscope, outer sheath, light source, and inflow, and often outflow. The endoscope consists of an eyepiece, a barrel, and an objective lens. The lens angle ranges from 0 to 70 degrees. The hysteroscope's outer diameter describes the total diameter of the endoscope, plus outer sheath. Operative sheaths range from 5.5 to 10 millimeters. This allows more ports for additional operative instruments. Diagnostic sheaths are smaller in diameter, ranging from 3.7 to 7 millimeters. Some hysteroscopes are able to accommodate a range of sheath sizes for both operative and diagnostic hysteroscopy. The length of the outer sheath is known as the working length. Longer working lengths facilitate procedures in women with a large uterine cavity and/or higher body mass index. Light is conducted through a fiber optic cable to illuminate the surgical field. The inflow channel delivers the distension media, which allows expansion of the uterus. Excess fluid will passively drain from the uterus. Some hysteroscopes may have an additional outflow channel. This allows suction of excess fluids to help optimize visualization, especially during operative procedures.
Yes, thank you. That is the
Thank
end
you.
of the.
Yeah. You continue. You continue, Vidya.
I once again thank you, and I once again thank Dr. Umiyal ma'am and Dr. Vijayalakshmi ma'am, Dr. Bhuvneshwari ma'am, and Vidya PG teaching program team for giving an opportunity to conduct the program today, and also to present the tidbits. And there was a mild audio technical error today, so I couldn't start the program in the initial stage. Thank you.
Sahiti, can you give the results now, or shall I read out the answers?
Please
Okay.
read the answers, ma'am.
Okay. What is the genetic molecular? First question, Sahiti. What is the genetic molecular alteration most frequently identified in the pathogenesis of uterine leiomyoma? It's MED12 gene mutation. Next question. What is the mechanism of action of elagolix, a medical option approved for managing heavy menstrual bleeding associated with uterine fibroids? It is an oral non-peptide GnRH antagonist. Third question. According to FIGO classification for uterine leiomyomas, a fibroid that is entirely intramural with no extension into either the endometrial cavity or the serosa is classified as type 4. What is the primary mechanism by which an intramural fibroid that does not distort the endometrial cavity still contribute to recurrent pregnancy loss or infertility? It causes altered myometrial contractility and focal endometrial inflammation with dysregulated gene expression. Fifth question. During a histoscopy resection of type 1 fibroid using a monopolar resectoscope, a non-conducting distension medium, 3% sorbitol or 5% glycine is used. At what fluid deficit threshold should the procedure be immediately halted to prevent severe hyponatremia and cerebral edema? The answer is 1000 ml. So this is the explanation for hypertonic solutions. Okay, the next question. When using a loop resectoscope to shave down a FIGO type 2 submucosal fibroid, which safety principle must be strictly adhered to in order to prevent mechanical uterine perforation? So always move the loop inwards towards the hysteroscope or operator, otherwise we will perforate the uterus. Next slide. So this is the explanation. Next slide. So ulipristal was highly effective at controlling bleeding and shrinking fibroids, but its clinical use has been severely restricted. What is the primary safety concern associated with UPA? It is drug-induced liver injury, option B. Eighth question. While preoperative treatment with GnRH analogs is highly effective for correcting anemia and reducing the overall fibroid volume, what is a well-documented technical disadvantage encountered during a subsequent laparoscopic myomectomy? Option C, obliteration of the cleavage plane between the fibroid pseudocapsule and the normal myometrium. So the cleavage plane is obscured. Ninth question. During a technically challenging uterine artery embolization, the interventional radiologist notes that the fibroid continues to show significant contrast enhancement despite complete bilateral occlusion of the uterine artery. So the commonest source of collateral arterial supply to uterine fibroid is obviously the ovarian artery, option E. So the final question, MRGFUS induces target tissue destruction primarily via coagulative necrosis. What is the target peak temperature range required at the focal point during a single sonication to guarantee irreversible cellular death? So the answer is 55 degrees to 65 degrees. So the results ready, Sahiti? Or you need some more time?
Yes, ma'am, I need some time, ma'am.
Okay, no problem.
So I would like to sincerely thank our dear judges for their valuable time and thoughtful evaluation of the case presentations. And I also thank Karpaga Vinayaka postgraduates for their sincere efforts and meticulous preparation. I thank Dr. Nitya for her enriching and elaborate session on hysteroscopy. And finally, I would like to thank Umayal ma'am, Viji ma'am, Bhuvaneshwari and Sri Sudha for giving us this opportunity to conduct PG Vaidya monthly. If it is taking long, can we put the results in the group, Sahiti?
Yes, ma'am, it will take some time, ma'am.
Okay, we will put the results in the group and we